Okay, dear colleagues, you're welcome to the second session of Gynecologic Laparoscopic Surgery course that is held by the MD Academy Turkey. Today we will talk about the overview of laparoscopic surgery and about the umbilical entry sites. As you know, we use laparoscopy for many procedures, and either benign or malignant disease, and we can perform every surgery that we are performing by laparotomy, and it has a big advantage in the field of surgery, gynecologic surgery. It has many advantages according to laparotomy, and these are less, patient will have less post-operative pain. The surgery will last shorter, and we will, at the end, the patient will have smaller scars, and the patient will recover faster. And of course, another advantage is decreased adhesion, and the cost is important at the end. Decreased cost is a controversy according to for countries like developing countries or undeveloped countries. In fact, it's an expensive surgery, but in developed countries, the cost of the surgery is not so much. Of course, before every surgeries, you have to evaluate the patient preoperatively, and you have to check the medical comorbidities of the patient, like hemostasis or ability to tolerate the surgery. And of course, during the surgery, you increase the abdominal pressure, and you have to confirm that the patient will tolerate this. And also you have to confirm for the risk factors of adhesive disease or umbilical or ventral hernia repair, because these may increase the risk of complications related to laparoscopic entry techniques. And at the end, maybe because of these adhesions, you may convert to laparoscopy to laparotomy. So you have to get the informed consent of the patient for this procedure. So before the surgery, you have to test the patient appropriately, including pregnancy test. You have to plan for the antibiotic prophylaxis and thromboprophylaxis. And bowel preparation is no longer a standard for gynecologic surgery, even laparotomy or laparoscopy. It doesn't differ. Of course, we are doing the surgery in the dorsal lithotomy position. For laparoscopic surgery, you have to be careful to avoid neurologic injury at this position, and you have to provide an ergonomic surgeon positioning by this position. And by this position, you allow the adequate access to the vagina if necessary. And another trick in this surgery is you tuck the arms of the patient beside her sides, and you make simple the surgery for the surgeon by this position. Of course, by dorsal lithotomy position, we provide access to the vagina. In this position, you maintain moderate flexion at the knee and the hip with minimal abduction and external rotation of the hip. You can use a bolster underneath the patient's buttocks to elevate the hips, and the buttocks of the patient will be a few centimeters beyond the edge of the table, because that allows you to manipulate the uterus. The monitor will be 15 degrees below the eye of the surgeon, and the monitor will be approximately 50 centimeters away from the surgeon. And we use a Trendelenburg position in the surgery to displace the intestines, so we can see the pelvic viscera easily. And of course, we decompress the bladder by a catheter, and also we compress the stomach by a catheter also. Professor Dr. Çalışkan has told about the instrumentation that we use in laparoscopy. So there is echo. We have many laparoscopes, imaging systems, devices for dissection and hemostasis. We have suction and tissue removal instruments. Today, we are lucky because we have all the instruments that we use for laparotomy are available for the use during laparoscopy today. That's a chance for us. So by these instruments, we can do complex surgeries easily. Of course, we use uterine manipulators, uterine cannulas to manipulate the uterus to make the surgery easier. And most of these manipulators also permit injection of a dye solution. And the mostly used reusable manipulators are, you see in the figure, Cohen cannula or the Hulka uterine manipulators. These are the simple ones. And of course, disposable and reusable manipulators which delineate the vaginal fornices are also used in the surgery. We use those manipulators for advanced laparoscopic surgery. As you know, we told in the last session, we commonly use the umbilicus as an access site to the abdomen. We use the other alternative sites when umbilical entry is risky or difficult. As a traditional technique, we use, as we told in the last session, varus needle, and the access site is typically at the umbilicus. We insufflate, we create the pneumoperitoneum, and we pass the first tracker at the varus needle site. The access site that we will use depends on the choice of the approach, and it's best determined by the surgeon's skills set. Here you see the access sites that we use in a classic abdominal, classic hysterectomy. This is a multi-port laparoscopic hysterectomy. You see the primary port is at the umbilicus. We generally use two accessory ports, and those are placed at the bilateral lower quadrants. And the lower quadrant ports are placed approximately 2 centimeters medial and or superior to the anterior superior iliac spine at the lateral border of the rectus abdominis muscle. And also you can use a fourth port, which is placed suprapubically or in the lateral abdominal wall at the level of the umbilicus. There are some risk factors when you use this abdominal umbilical access site, and those are peri-umbilical adhesions. If there is a mesh beneath the umbilicus, it increases the risk of complication. Maybe the patient may have umbilical or ventral hernia. Maybe the surgery you are doing is for a big, large pelvic mass. Patient also may be pregnant. The uterus will be larger, as you know, in pregnancy. So in these situations, surgeon will prefer non-umbilical access sites. It may be abdominal or non-abdominal under these circumstances. In these situations, we can use non-umbilical access sites, one which is 9 intercostal space. The mostly used non-umbilical abdominal access site is Palmer's point, which is 3 centimeters below the left costal margin in the left mid-clavicular line, and also other sites in the midline abdomen can be used for non-umbilical access site. Also, non-abdominal access by the uterus or posterior vaginal valve cuff has also been reported, but they are rarely used. For example, posterior vaginal fornix is a useful site for laparoscopic entry, and this site has been used primarily for the insufflation. Also, today, another popular topic is natural orifice transluminal endoscopic approach, both for gynecologic and non-gynecologic procedures. How will we access from the posterior vaginal fornix for the insufflation? You, in the Trendelenburg position, you hold the posterior lip of the cervix, you elevate the cervix and insert the varus from the posterior fornix into the abdomen. And do not push it more than 1.75 centimeters. You have to stay in the midline always, and do not advance the needle more than 3 centimeters. And you begin insufflation, and intra-abdominal pressure less than 10 millimeters mercury indicates peritoneal placement. Then we remove the varus needle and insert the trocar at the other side. Mostly we use, as we told before, the umbilical access site, unless it's risky to use this access site. Also, we can use optical trocars, radially expanding trocars, and open techniques through the umbilicus to avoid the failed insufflation and injury during the surgery. While the candidates for non-umbilical access sites, there are some anatomic factors or conditions that may increase the risk for complications, and these are known or suspected periumbilical adhesions, or any periumbilical mesh, or any hernia at the umbilicus or ventral abdominal wall, as we told before, large pelvic mass, and pregnancy. Who will suspect from the adhesive disease if the patient had a bowel obstruction before, or any prior intra-abdominal surgery, or if the patient has a malignancy, or if patient had an abdominal infection before, the suspected adhesive disease risk increases. Also, those who have had a periumbilical incision are at risk for adhesions of the omentum of the bowel to the anterior abdominal wall. And the estimated risk for adhesion is the patient had no surgery before, 0 to 5% risk of adhesion. If the patient had a previous transverse suprapubic surgery, 20 to 30% risk of umbilical abdominal, anterior abdominal wall adhesion risk. And if the patient had a previous midline laparotomy, the risk increases to 50 or 65%. And also, if the patient had a prior laparoscopic surgery, there is a risk of 2 to 21% of anterior abdominal wall adhesion. Of course, if the patient had any abdominal wall, ventral wall herniography or surgical mesh, you will avoid the entry from the umbilical side because there is a high likelihood of adhesion to these sides. And the patient has a hernia, the umbilical entry will disrupt this hernia. If the patient has a large pelvic mass, you have to avoid to puncture this mass. It may lead to bleeding, or if you may puncture an ovarian malignancy, and you may worsen the prognosis. And also, you can calculate the point of contact of the insulating instrument. The length of the standard varus needle is 12 centimeters. You can calculate the distance by this. And also, the risk of trauma during abdominal umbilical entry depends on the size of the gravid uterus, if the patient is pregnant, and its position relative to the umbilicus. Of course, this is another lesson for laparoscopy in pregnancy. The patient may be obese. We elevate the abdomen who are not obese to avoid vascular injury and insert the varus needle by a 45 angle. But if the patient is obese, this 45-degree angle will not be enough to reach the peritoneum, and we will fail to insufflate the peritoneum. In obese patients, you insert the varus needle at an angle closer to the 90 degrees approximately. And of course, patient can be very thin, and in this situation, there is an increased risk of injury, especially major vascular injury, and the use of a 45-degree angle from the vertical may not be protective, so we have to be very careful in these thin patients. Also, abdominal wall laxity may prevent peritoneum insufflation because it's hard to enter the peritoneal cavity if the abdominal wall is laxative. In patients in whom we will use non-abdominal umbilical abdominal access sites, the first decision is to whether Will we use this site for just for insufflation alone, or also for tracheal insertion? If the blind insertion of any instrument at the umbilicus is contraindicated, then insufflation and tracheal insertion should be performed at a non-umbilical site. And the most used site is Palmer's point, which is 3 centimeters below the left costal margin, the left midclavicular line. So we can use this point for insufflation and trocar insertion also. Most of the other sites are used just for insufflation and followed by trocar insertion at the Palmer's point or the umbilicals. Also, in the first session, Professor Dr. Çalışkan told about the complications. This is also controversy for me. The reported overall complication rate of laparoscopic surgery is about 5 per 1,000 procedure. But this is too low for me because nobody is reporting his or her complication rate. And this is not, I think this is not the real overall complication rate for the surgery. And the reported vascular complication rate for gynecologic laparoscopy is 0.09%. Also, this is also too low, I think, but it's reported in the literature. It's low because nobody is reporting, as I told before, reporting their complication rates. In the major vascular injuries, the most affected vessel is inferior epigastric vessels and iliac vessels, aorta, and inferior vena cava. And again, I think that these complication rates are too low because nobody is reporting his or her complication rate. These complication rates are reported by the advanced laparoscopists, so they are too low because everybody is doing laparoscopy. If surgeon is a beginner laparoscopist, his complication rate will be higher, and after the learning curve, when he is a moderate laparoscopist, his complication rate will decrease. If he is an advanced laparoscopist, his complication rate will be much lower, of course. And most of the complications, the entry is an important part of this surgery. 50% of the complications happen at this entry, and 20 to 25% of these complications are not recognized until post-operative period. You see 82% of injuries occurred during abdominal entry, and 93% of these vascular complications are recognized intraoperatively, and half of them require laparotomy to repair them. And this was the first session. Now, let me talk about some guidelines for laparoscopy. Let me open both. Okay. Here is the guidelines of Society of Obstetrics and Gynecology of Canada. They have published this in 2020. It's a new guideline. They have 13 recommendations at the end of this guideline. They recommend, this guideline is published by the Society of Obstetrics and Gynecology of Canada. It was published in 2020, and they have 13 recommendations at the end of this guideline. If the patient, they advise that, they recommend that if the patient has any adhesion or risk of adhesion or history of umbilical hernia or ventral wall, abdominal wall hernia, they advise to use the Palmer's point. The evidence of this, quality of evidence of this recommendation is two. The first number declares the evidence of this recommendation, quality of evidence for this recommendation. And in the second line, they do not recommend to perform safety checks for the insertion of the wireless needle. And the quality of evidence is also true for this one. But they advise you not to waggle the wireless needle from side to side because you can increase the injury side by this. They also recommend when you create the pneumoperitoneum, the intra-abdominal pressure less than 10 millimeters mercury is a reliable indicator that you are in the abdomen. So they recommend you to attach the gas to the wireless needle when you are inserting it to the abdomen. And also the quality of evidence for this recommendation is also true. They do not routinely recommend the elevation of the abdominal wall. That's another interesting recommendation for me because we always elevate the abdominal wall. We elevate the abdominal wall by the fascia, anterior fascia of the rectus abdominis muscle. And also they also recommend that in non-obese patients, you will use a 45-degree when you are inserting the wireless needle to the abdomen. If the patient is obese, you can use a 90-degree when you are entering the abdomen. They recommend that the adequate pneumoperitoneum is determined by the intra-abdominal pressure. It's not determined by the carbon dioxide volume. When you are entering the abdomen, when you are insufflating first, if you are not using direct trocar entry, you can make high intra-peritoneal pressure laparoscopy. First, you enter the abdomen by wireless needle, and the highest pressure that you will do the surgery is 15 millimeters mercury. But at the beginning, you may increase it to 20-25 millimeters mercury before you enter the trocar. So you can use this technique, and the quality of evidence for this recommendation is also true. because it does not adversely affect the cardiopulmonary function of the healthy patient. They recommend the open entry technique, which is an alternative to wireless technique, but they also recommend that there is no evidence that open entry technique is superior or inferior to the other techniques. As I told in the first session, I am doing open laparoscopy, and I believe in open laparoscopy because all of the other techniques are blind techniques. And as the complication rates are similar for these both techniques, but as I told previously, nobody is reporting his or her complication. These overall complication rates are not real. For me, I think so, because they are reported by the advanced laparoscopists. The complication rate of beginner laparoscopist or moderate laparoscopist, we don't know those complication rates. And they also recommend another technique, direct trocar insertion without any pneumoperitoneum. It is also an alternative technique to wireless needle technique, and the complications rates are also similar for this technique. You do not use wireless needles, you do not insufflate abdomen, you do not create pneumoperitoneum. You directly enter the abdomen by the trocar. And also they recommend that direct insertion of trocar is associated with less insufflation-related complications, and of course, it's a faster technique than the wireless needle technique. Also, shielded trocars, I have never used, but I have seen. They recommend that there is no evidence for the fewer visceral and vascular injuries during the laparoscopic access by shielded trocars. Mostly in Turkey, the gynecologists are using this direct trocar insertion technique. Approximately nobody is using wireless needle. Further, nobody is using shielded trocars. Nobody is using visual trocars. Mostly are using this direct trocar entry technique. Also, radially expanding trocars, they are not superior to the traditional trocars. They do not decrease the injury rates. I have never used this radially expanding trocar. I have also seen, and it's not superior to the other traditional trocars. And also visual entry trocars, they are also not superior to other trocars. I have once used this visual entry trocar, and it's not an easy and a fast technique, and they are not superior to other trocars. They have recommended these 13 recommendations. Yes, this was the last slide. Again, I am telling you that I am doing open laparoscopy. For me, it's the safest way to reach the peritoneum, and I don't believe those reported complication rates because they are not the real rates, because nobody is reporting his or complication rate. They are the rates of the advanced laparoscopies. I think that the complication rate is higher than these numbers. Okay, thank you very much for listening to me. This was the last session of this online course, and we are hoping to see you in Istanbul again. We will have live surgery in Istanbul. If you come and join us, we will be happy.